First of all, let me thank you for the invitation to come here. I had the opportunity yesterday to already speak to some honorable members of your university and during a nice dinner and speaking on psychedelics and the use of psychedelics more in a broader sense. But today I was invited to speak about the use of psychedelic-assisted treatment in addiction as a specific topic. And the subtitle that I chose is this a new solution for old problems? And so I will try to show you that there is quite some promise there and that we should follow that intensely. So, but before I go there, I have to make all kinds of statements about disclosures. I worked for a long time in the field of addiction psychiatry, and most of my research was financed by state agencies, but I did work together with pharmaceutical industries, and it's very interesting that pharmaceutical industry lost their interest actually in psychiatry some time ago, and new, smaller and larger companies are getting more interested in psychiatry again now with the psychedelics, so something is going on. In psychedelics, I worked together very briefly with Janssen, and you might know Janssen from the ketamine nasal spray, and I worked together with Clear Mind Medicine. That was a company in Israel. If I come to these issues, I will say where you have to be careful with me, that you shouldn't trust me on my, I don't know what type of eyes I have, blue eyes probably. So what I want to say is a few words on psychedelics, but I don't have to say so much anymore because it was done before. A little short history, and Ethan actually was referring to that already a little bit. And so I will basically talk about what we know now, quite specifically about the effects of psychedelics in the treatment of addiction, and a little bit on the other mental disorders. Why also on the other mental disorders? Because actually, as I see it, I don't see in my practice any patient with an addiction who has not any other mental disorder. So we really have to look at this comorbidity. And if these medications are not only effective in addiction, but also potentially in other mental disorders, this could actually be a way to treat people with these comorbid disorders. I will say a few words on mechanisms of action. There is no definitive answer there. There is ideas, there is quite a lot of research being done about it, both in the fields of psychology and philosophy, as in the neuroscience world, both in the preclinical and in the clinical neuroscience world. A lot is going on there. At the end, it's very interesting, and we should know that, but at the end, people want to know, does it work or not? And can we actually treat patients that are not treatable so far? And so that is the end of my talk. I come to psychedelics as a potential solution for existing problems in addiction treatment. Now, these are the psychedelics that have been mentioned. Classic psychedelics, also called the serotonergic psychedelics, working on as a 5-HT2A receptor agonists, LSD, psilocybin, ayahuasca, mescaline, 5-MeO-DMT. These are the classic psychedelics. Then there is a group that we call atypical psychedelics, or some people call it atypical psychedelics. They share certain characteristics with the classical psychedelics in their effect. Actually, chemically, they're quite different from the classical psychedelics. Like we have MDMA, which is actually a serotonin releaser. It's also called empathogens or entectogens. They increase empathic feelings and relationships. Dissociative compounds, and these are basically working on the glutamate system. And the example is ketamine and other compounds, and there's quite a lot of them, but the most important one is probably ibogaine. And I will say very little. It's a complex compound, and I'm not sure that we will work with that for a long time. This is the history, but very different from the way Ethan Edelman did it. This is the history of publications about psychedelics between, I don't know whether you can see it, between 1943 and 2020. And you see the number of publications was very low. It was non-existing in 1940. It went up, and it had a peak around 1960, and then you see it went down completely, and now, since the end of the 1990s, it's steep going up in number of publications. And so why was that? One of the things is, of course, what Eden said. There was this big thing in the 1960s with the time of peace and love, and Timothy Leary proclaiming that if we all start to use psychedelics, peace will come. And that was in the time that the Vietnam War went on, of course. And this was a very dangerous statement, according to President Nixon. And so that's where, in 1976, started the war on drugs. And actually, it became forbidden to work, also scientifically, with psychedelics and other drugs. And so there was a big stop in the studies on psychedelics. And that's what you see here. So it's a pre-Schedule 1 and a post-Schedule 1 period. In addition, I think in the late 1990s, there was also a crisis in biological psychiatry. There were no new medicines coming into psychiatry, and I think people were thinking that this is over. Biological psychiatry is dead. And so this was the reawakening of biological psychiatry. The psychedelics came, and you see that it's the psychedelic renaissance, it's sometimes called, and suddenly you see neuroscience is about these things, and you see the coming of randomized controlled trials. So you have the period of the early studies of psychedelics in psychiatry, and the period of the modern studies actually in this in the 21st century. So psychedelic as a medication, the early studies, then came this big change in the United States and the rest of the world, and then we have the modern studies, and you see there's many of them and many more coming. What do we know about the early studies? You see here a very nice study with a person that is healthy control, and they gave him LSD because they thought LSD gives you experiences that look like a psychosis, like schizophrenia. And so they were studying these healthy controls to see whether we can learn something from that. But by now we know this is a completely different thing. The psychosis that you get from LSD, which is not a real psychosis, but it looks like it, and the ones that you get in schizophrenia. This is, as I told you, mainly a serotonergic effect. And what we think now about schizophrenia, that it's, if anything, it's mainly dopaminergic, maybe glutamatergic, but that is more the model that we have now. So I think it was a lot of misunderstood studies there. But there were also studies in patients with what we now would call probably depression, anxiety. At that time, it was most of the time called neurosis. Hundreds of studies in patients with neurosis. And most of the studies showed promising, but they were of very low quality, and there were no randomized controlled trials, and they were all done with LSD. There were also studies in what then was called alcoholism. They were generally from a slightly better quality, and at least in that period there was something like 8 studies that you could call reasonably good. And 6 of them were randomized controlled trials, and they used LSD, generally without any psychotherapy, but in what they call pleasant environment, which is not normal in that time in the 1950s and 60s if you went to the American Psychiatric Institutes. They were not nice environments. The outcomes were rather inconsistent, but recently 2012, they were a group of Scandinavian researchers. They looked at these 6 randomized controlled trials with LSD out of the 50s and 60s, and they did a meta-analysis. And what they showed is that actually over a period of 3 to 6 months, they had clearly effects of LSD on reduced drinking and on continuous abstinence. And they compared it to the effects of what you see with modern medications for the treatment of alcohol dependence, like naltrexone, acamprosate, and disulfiram. If you give these modern medications on a daily level, they're less effective than you give once a single dose of LSD over a period of 3 to 6 months. So it is an interesting way looking at these old studies showing great promise of LSD in the treatment of alcohol dependence, then called alcoholism. So how is it with the modern studies? We have a lot of studies by now. Some are better than others, but I want to give you just a flavor of how it is being studied now in addiction. First start with ketamine. Ketamine has a long history of studies in patients with substance use disorder. So I made a distinction between the Russian studies and the US studies. The Russian studies were early, much earlier than the American studies. They were basically done with people like Yevgeny Grupitsky from St. Petersburg. And nobody looks at them anymore because they come from Russia, so nobody trusts them. I think if you start to look at these studies, they look quite sophisticated. They were earlier and more sophisticated than most of the other studies at the time. They did quite a big study, a controlled study, not randomized, but a controlled study in alcohol with very nice effects. They did randomized control studies in heroin-dependent patients over a period of 24 months. So they got ketamine, Q-exposure therapy, and integrative psychotherapy, most of the time 2 sessions, or sometimes 3 sessions, and they had long-term outcomes, 24 months, compared to the placebo, 70 versus 2%. Numbers needed to treat of 6.7. Numbers needed to treat is you need to treat 6 patients in order to have 1 more patient to benefit from it. And they had randomized control trials comparing 3 times ketamine and 1 time ketamine, with also very nice effects. So these are the early studies. We don't believe in them anymore. They're not being mentioned anymore, but they're still, I think, an interesting start. Then comes the studies from the 21st century from the US. And with ketamine, we have 3 crossover lab studies with cocaine self-administration, alcohol self-administration, and we have randomized control trials. I'll take you through it. It's an interesting thing. This is how it started. It's very nice to work in a laboratory, and you ask patients to come in and you say, I'm going to give you medications, crossover, and you're free to use cocaine as much as you want in our laboratory. And see what happens. They had ketamine and as a control condition, lorazepam. So if these patients were under lorazepam, LZP, you see there is no increase on motivation, but as soon as they cross over to, dit gaat niet goed. Yeah, as soon as they move to ketamine, K1, then you see an increase of motivation. The same you see here. As long as they get lorazepam, nothing changes in cocaine craving, but if they go to ketamine, you see a big reduction in craving. And so that's the first indication that ketamine can actually reduce craving. This is another study that they did in the same laboratory, and they made very clear that if you compare midazolam, the control condition, with ketamine, ketamine gives more mysticism, gives more near-death experiences, gives more dissociation, and also gives better improvement, less craving and less cocaine, yet self-administration. And so they looked a little bit what was predicting the reduction in cocaine use and craving, and it basically was the measure of mystical experience. You see, the more mystical experience, the better the improvement in reduction in cocaine use in the lab and the craving. So it seems that the mystical experience, even with ketamine, which is really the least typical or the most atypical, mystical experience was important in the effect. These are the modern studies. This is a study was published in 2019. It was a study in coke independence. It's a population of 55 patients who were randomized to get either ketamine IV 1 dose or midazolam 1 dose, and they got weekly sessions of mindful-based relapse prevention. And so what you saw very clearly in this study is lower dropout rates, like in the control condition. Only 93% actually dropped out, and in the ketamine it was only, not only, it was 60% dropped out. But you see here, this is the midazolam, the control group. They kept on using cocaine, and you see here with the ketamine, they reduced the cocaine to 40% of the total. So strong effects over a period of only 5 weeks. This is not addiction, of course. Addiction is a chronic disease. You want to have effects not over a period of 5 weeks, but over a much longer period. This is a very similar study, also comparing ketamine and midazolam, but then alcohol dependence, the study lasting 21 days, 3 weeks, not very long, but again, you see very strong effects. You see abstinence at 21 days, 90% versus 60%, numbers needed to treat of 3, which is a very large effect size in what we know in psychiatry by now. Abstinence at 6 months, they looked at these people also at 6 months, 75% in the midazolam group and 75% abstinence in the ketamine group and 27% in the midazolam group. Numbers needed to treat of 2. So I'm not going into all the details, but you see potentially very strong effects over short periods of time, but even in the longer periods of time, ketamine on alcohol in this case. And this was the first real phase 2 large randomized control trial in alcohol-dependent patients. It was a randomized control trial done published in 2022, and they compared 3 weekly intravenous ketamine infusions versus placebo. They also received either mindfulness, relapse prevention, or education, and they looked at 3 weeks and 6 months follow-up. And these were the effects. This is the effects over 24 weeks, or that is 6 months. So then we start to talk about addiction. Addiction is a chronic relapsing disease, and you want to see over a longer period of time that these 1 to 3 injections with ketamine did anything. And so what you see a significant effect at 3 months, but also a significant effect on 6 months. So you see an effect here, and you see an effect here. There was a non-significant effect of ketamine in 6 months on relapse, whether there was any relapse, but there was in the right direction. There was a significant reduction in depression. There were 6 patients in this study that used illicit ketamine next to the ones that they got from the treatment staff. They were all in the control condition. So it wasn't that the treatment with ketamine installed a ketamine addiction. So this is the next study that's coming up, and you see it's going quite quickly. This is a study on racemic, intravenous racemic ketamine. This is how long it takes from the planning of a study. This study was registered as a study in 2023. We expect the trial to complete in 2027, 4 years, and to be authorized for marketing 2028 as the earliest. You see, it takes 5 years. So we have to take that into account if we talk later about the future. This is an interesting one. So far, we have no medical treatment for cannabis dependence, and this is the first study of the use of cannabis, the use of ketamine in the treatment of cannabis dependence. And so what you see here is that it's a pre-post study. It's not randomized controlled trial. It's the beginning. It's really the beginning. And you see a very quick effect in terms of the days that we're using cannabis, pre and post study. And so this is just the first sign that it's not only ketamine, if it works, it seems to work in alcohol, it seems to work in cocaine, and it might work in cannabis. So given the fact that you will see the same in your patients, I don't see patients with only alcohol dependence or drug dependence. I see patients with polydrug dependence. So here's at least a medication that if it turns out that it works, it seems to work also in polydrug addicts. So this is solving one of the serious problems that we have in addiction medicine. So the modern studies, MDMA, there's very little known about it. Actually, there's only one study. This is the only study from Ben Sessa. Don't believe him. He's an idiot. He says there is no effective medication in psychiatry except MDMA. That is rubbish. Come on. We want to see. He did the first study, so that's nice that he did it. And so we have an indication that if you treat alcohol use disorder patients with 2 sessions of their MDMA with psychotherapy, that it seems that over a period of 9 months, you see a large reduction in the amount of alcohol that's being used from 131 units a week to about 19 units a week. And you see in terms of the 14, in terms of abstinence, you see 21% still using alcohol in the ketamine group, whereas it in an external control group, so it's not a randomized control, it's 75%. So it's a first indication from a researcher that I have doubts about his credits. So it's the first sign of MDMA. Psilocybin is a different story. So this is, by now there are more reviews than there are studies in psychedelic research. This is the first study, and I think it's a very nice one. It's from Matthew Johnson. It's a pre-post study. It's not a randomized controlled trial, but you have to realize he looked at 15 patients, and he gave these 15 patients with a chronic smoking tobacco dependence. They were 31 years smoking. They had at least 6 stop attempts, so they were really chronic smokers. And you know, it's not easy to treat these people. But after 3 psilocybin sessions, 12 of these 15 smokers were abstinence for 6 months. 80% had 6 months abstinence. And the 3 that didn't become abstinence started to use much less cigarettes. So it's a pre-post study, so you have to be careful. Maybe it's not true. And again, he looked at all kinds of psychological parameters, looking what could explain the difference in craving. And you saw mystical experiences were, again, one of the driving forces of the reduction of craving in this study. This was a very similar study from Michael Bokenschutz from New York, and he was looking at alcohol-dependent patients. Again, a simple study, pre-post. Not so strong, pre-post, but you saw very quickly after 2 sessions of psilocybin with psychotherapy, a quick reduction in the alcohol use, both in the percent of drinking days and the percent of heavy drinking days. And it was lasting for 4 to 6 months. So that is a new indication with the psilocybin plus psychotherapy that if you have effects, you have long-term effects. But this is a pre-post study, so I have to be careful, don't believe them immediately. But Michael Bokenschutz did recently, study that was published in 2022, a large randomized control trial, relatively large. A randomized control for 95 patients with alcohol dependence, treatment for 12 weeks, and a treatment-free follow-up period of 20 weeks. So here you start to look at long-term effects. The treatment, the experimental treatment, is 12 weeks of motivational interviewing and cognitive behavior therapy, and 2 doses of psilocybin, and a control condition, same psychotherapy with 2 doses of diphenhydramine as an attempt to blind the study. So they looked at week 5 and week 32, and this is what you find. Here, this is an important thing. They tried to blind, but the blinding was ineffective. They couldn't blind the patients. They knew whether they got psilocybin or the dihydrophentamine. They also looked not only at the self-reported alcohol, they also looked at alcohol according to acetylglucuronide in urine. So at least there was also an objective measure of outcome. Again, here's the dimensional outcomes. You see percent heavy drinking days over this period of 20 weeks. Quite a big difference. Here's the effect sizes. For people who don't know that an effect size of 0.50 is generally what we not see in psychiatry. We see most of the time effect sizes around 0.30 to 0.40. This is 0.50 over a long period of time. And the same is true actually for these dichotomous outcomes. Numbers needed to treat here, for example, around 4, which again is a very large effect size in this nice randomized controlled trial with both self-reported outcomes and urine analysis outcomes. They also looked a little bit of these patients, when the patient changed in their personality. Now, you might think, do you want to change your personality by treatment? I actually always thought that that's what I don't want. But then I realized afterwards that I've been in psychotherapy quite a lot, either for the training or for real issues. So maybe I changed. These people change after they have the psychedelic experience. Is it bad? I don't know. They become less neurotic, reduced neuroticism, increased in extroversion, and they increased in openness to experience. All in all, they got a more normal personality profile, with the exception of openness to experience. They're more open to experience than the general population. So do we want that? Is that fun? Is that good? It's for you to discuss. This is ibogaine. It was mentioned by Nita Nadelman. It's actually one of these strange drugs. It's an alkaloid from plants from Africa. And it was in the Netherlands. It has been in the US. It has been in many places. Actually, I think the Australian Society of Psychiatry actually gave permission to use ibogaine. I think there's problems with it. Ibogaine is a complex thing. There has been quite some studies in opiate detox. At the end, detox is interesting, but we're not looking for detox. We look for abstinence or reduced use, of course. And so there's a few studies, not great studies, no randomized controlled trials with ibogaine. This is probably the best one that we know. It's the Brown and Alper study. And it started with 30 patients. And you see 1 month, 3 months, 6 months, and 12 months later, there are not so many patients left. And you see the number of subjects that are still abstinent and are still in the study. You see that it's 15 after 20 weeks, but 7 after 12 months. Anyway, however people dropped out, 7 out of 30 is still 23%. I never saw studies that showed 23% continuous abstinence with opiate dependence. So it is something, but I think there is a lot of, maybe I should mention this one also. This is a study that is quite recent. What is it? 2024. It's a prospective pre-post study, not a strong design, you have to be careful. In 45 special operation forces, veterans in America and Mexico, with alcohol use problems, some with and some without PTSD symptoms. And they received one session with ibogaine, and 3 days later, one session with 5-MeO DMT, which is a very strong classic psychedelic working something like between 20 and 40 minutes. So why they did it, it's not very clear, but it's quite an aggressive treatment. What I want to show is what is interesting here. It has a big effect on alcohol. That's what they wanted. But there were also 19 patients with PTSD comorbidity, and there was also a big effect on PTSD. And finally, there was a very nice effect on cognitive functioning. So you see this psychedelic treatment in a group of patients with an alcohol use disorder, with comorbid PTSD, it had a good effect both on the alcohol use disorder and the PTSD and cognitive functioning. But ibogaine is a problematic medication. This is a study from the Netherlands. They took 14 heroin-dependent patients in a clinical setting, and they start to look at what happened during the detoxification. First, they also looked at detoxification. Then they gave this ibogaine, and there was a massive increase of QTc prolongation, which is, it means that the signal, the electric signal in the heart is different. And this might lead to ventricular fibrillation. And there are cases where it's reported cardiovascular death. And we saw 55% of the patients had a maximum QTc more than 500 milliseconds. There was no torsade de pointe, no ventricular fibrillation, but it's a very risky situation. And even after 24 hours, there was 43% with an increase of the QTc elongation. So this is a serious cardiac risk, which you don't see with all the other psychedelics. So I think ibogaine wouldn't be my first choice in psychedelics. Here is another study that shows the risks of ibogaine. It's out, I think. This is the new kid in the block, 5-MeO-DMT, I told you already. It's a medication that, like LSD works about 16, 17 hours. Psilocybin, 12, 13 hours. It's in clinical practice a little difficult, isn't it? You sit with two people, two therapists next to your patients that is in the session for 12, 13, 14 hours. MDMA is a little better, 6, 7 hours. MEO-DMT, 20 to 40 minutes. It's a very strong and intense psychedelic experience, but it's short. So in terms of feasibility in general psychiatric practice, probably much easier. This is a study that's going on in London. People are being recruited, and I expect that we will have the first data from this 5-MeO-DMT somewhere next year. So that is a new development, so I can't show the data. This is what is going on. So my conclusions is that if you think about psychedelics and addiction, that ketamine, there is quite a lot of good, but generally relatively small studies. But there is also now one large RCT in alcohol dependence. So I think ketamine is a very promising medication because it seems to work for very different substances. MDMA, I think there's only one small pre-post study by Ben Sasson. And I think it's questionable whether it's going to work. We'll see. Ibogaine, there is some pre-post studies with a rapid and large effect, but the cardiovascular problem, I think, is really problematic. And so, as a researcher and as a therapist, I would stay away from it. With regard to the classic psychedelics, LSD studies are, I think, very promising. Their studies, some are old, but they're relatively good quality, so it's promising. The only thing, the time that it takes before the effects worn out is very long, so I think LSD studies will probably not be done. They will be replaced, I guess, by psilocybin studies. Psilocybin, 2 small pre-post studies and 1 very nice randomized control trial with a rapid and sustained effect and also clearly affect the mechanism of action through mystical experiences. I think it's very promising. Ayahuasca, I think there's no methodologically strong studies so far with ayahuasca and addiction. And 5-MeO-DMT, no studies yet available, but I think there is promise there. So there's a lot of promise. This is actually, if you want to read most of it, after I prepared this presentation, just a week ago, this study came out, and it actually summarizes what I said actually quite nicely. Psilocybin for alcohol use disorder, ketamine for alcohol use disorder, ketamine also for cannabis and cocaine use disorder, maybe also for opiate use disorder. So this is the current state of affairs, that there's a lot of promise. There's no medication for no indication addiction that is already at the stage that it will be filed to the European Medicines Agency or the Food and Drug Administration, but it's underway, I think. These are the problems that we have in addiction psychiatry or in addiction treatment in general. One is the thing that there's many available treatments now, but there's low treatment retention and high dropout in most of our medical treatments for addiction. There's many available effective treatments, but the effect size are quite limited. Numbers needed to treat anywhere between 7 and 10 or 11. Effect sizes of 0.30, 0.40. So small effect sizes. There's a lot of psychiatric comorbidity and little evidence of the effective treatment of this psychiatric comorbidity. And finally, there's a lot of polydrug addiction instead of just one drug, and there is no clear effect on the other drugs if you use one medication. So maybe psychedelics might be a solution in that. And for that, I started to look very quickly. Yeah, I can still do that. At some of the other areas where psychedelics have been studied, like depression, general anxiety disorder, and PTSD. I just do it very summarizing because people have said, ketamine, we know it works, it seems to work in addictions, in different addictions, and it is already registered for depression by the FDA and by the European Medicines Agency. So there definitely we have a proven effective treatment. Psilocybin, I think it's likely to be registered for depression in the very near future. The studies look very promising. There's a lot of money available. There's a lot of drive. So I think maybe this year or otherwise in 2026, I think that psilocybin will be registered for the treatment of depression or treatment-resistant depression. Psilocybin shows promise for the treatment of generalized anxiety disorder. There's a large randomized trial from Australia now, not yet published yet, but it was presented at the ICPR in 2024. And in June 2024, you all know it probably, MDMA-assisted treatment was almost registered for PTSD by the FDA, and it wasn't. For many reasons, we don't know what the reasons really were. This is the reasons that I think that it might have been not registered. One is, they were not blinded, the studies. But it's very strange. The FDA knew that. And despite that, they said that it's a breakthrough medication. But they were not blinded, the study, failed blinding. And there were high expectations, and that might be a reason for previous MDMA use. There were limited sample sizes. Now the question is, do you want large sample sizes? These were phase 3 studies with around 100 patients for any. That is small for a phase 3 trial, as we know them. But with these large effect sizes, you don't need bigger studies. So, is it a reasonable? Questions about the standardization of the psychotherapy. My answer would be, it doesn't make a difference. We know psychotherapy works. The type of psychotherapy never make a difference. We have never seen any difference between the effectiveness of different types of psychotherapy. Unjustified questions about abuse and dependence liability. MDMA is not addictive. Come on, this we know for a long time. And there was incomplete reporting of serious adverse events, and there was one case of sexual assault, and that's serious, but I'm not playing it down, but I don't know any field in medicine where there is not a case of sexual assault. It's everywhere. It's not a reason not to reject. Anyway, it was rejected. This is one of the studies, and it's important to show the effect sizes were really large. This is the first phase 3 trial that was done. You see on PTSD symptoms, the effect size was 0.91. That is called a large effect size. Rare in psychiatry, rare in medicine. In terms of social functioning, nice effect size. In terms of reduction of depression, nice effect sizes. So this is really what goes on. It's quite amazing. Numbers needed to treat for no diagnosis of remission around 3-4. It's a very nice effect size. This was an interesting finding. There were some patients in this phase 3 study that were using alcohol. They didn't have an alcohol use disorder because they were excluded, but you saw that the people who got MDMA had a larger reduction, significantly larger reduction in their alcohol use. So it gives you an indication that if you start to treat people with comorbidity with the psychedelics, you might treat both conditions at the same time. This I'm not going to into because it's no time anymore. Safety, I think we have to look at that much more. We need long-term follow-up studies, naturalistic follow-up studies to see what the long-term safety of these medications is. This a review that we wrote 2 years ago, and we looked at quantitative and qualitative studies. Acute adverse events, nausea, headache, anxiety. Late adverse events with psilocybin, MDMA, there is nausea, headache, so it's persisting, so we have to look at that. There was only one case of serious adverse events and with full recovery, but it's something to look at. This is something that we really have to look at it. In a small number of cases, we see what is called the hallucinogen persistent perception disorder. People, after they use psychedelics, they have a visual problem, and it's, their eyesight is getting blurred. And we don't know exact treatment. There are some treatments being used, but it's really something that's not resolved yet, and we have to be careful with that. Mechanism of action, I'm not going into that. Read this article from Van Elk, and you will get a wonderful overview. It's fantasies for a part. But we're getting closer to the mechanisms of action. They're defined at the level of the pharmacological level, and then you have to think about the neurocognitive level and the psychological level. There are theories of all these levels, and time will tell what is the real answer to that. And so, finally, is it a real answer to the problems that we have in addiction treatment? Maybe. As I told you, these are the problems. And as you see, the effects with psychedelics, they occur very rapidly before people drop out of the treatment. So that is a nice thing. The effect size seem to be large and long-lasting. So smaller problems that people have early relapse in the treatment. Psychedelics seem to be effective in addiction and many other mental disorders. So people with comorbid other disorders might be good candidates for the treatment with psychedelics. And finally, psychedelics seem to be effective in different addiction, like alcohol and ketamine and opiates in the treatment with ketamine. So the poly substance use disorder might be better treatment with these medications. There's also remaining issues, and you can make a picture of it. You can also probably get the slides from the organizers, I guess. This is just to mention the last thing. It's very promising, but it's still a long way to go for addiction treatment. I think for the treatment of PTSD with ADHD, with MDMA, I think it's ready there. We're going to do it. And maybe you're going to do it. Maybe not Iceland, but Latvia. And for the treatment of depression with psilocybin, I think it will be this year or next year, it will be registered. But for the treatment of alcohol or drug dependence with psychedelics, I think it's a little further away. It's not 10 years away, but it might be 3 to 5 years away before we have the first registered medication for the treatment of alcohol or drug dependence. Thank you very much.
So thank you very much for this comprehensive, but most importantly, critical review on existing status of the art. But we don't have actually much time for questions, except I want to ask you how lasting is the effect of psychedelics after the trials are stopped? Are there any follow-up, long-term follow-ups?
Yeah. Most of the trials, the new trials mainly show that after you give the 2 or 3 sessions of with the psychedelic treatment, they follow them up for 20 to sometimes 40 weeks, and the effects is lasting for 20 to 40 weeks. That's definitely true for the classic psychedelics. They're always in combination with psychotherapy. With the ketamine, it's a little less clear, but at least in the randomized trial, they lasted for 6 months, but it was with psychotherapy, which is very different from the studies that you see in depression with ketamine. The effects are most of the time relatively short, anywhere between 3 and 14 days is the effect of ketamine on depression. And so what you see is you have to have repeated sessions of ketamine over the time. And so people do start to worry about whether ketamine could become addictive in these long-term antidepressant treatments with ketamine, or that there might be bladder problems due to ketamine in these long-term studies. So it's a little bit different from what we see in the modern studies with addiction, where it is always in combination with psychotherapy. Now, I'm not sure that it's because of the psychotherapy or because of it's a different disorder, but at least with these studies we see long-term effects.
So still the psychotherapy should be combined with...
I think as long as we don't know, we should do that. But there should be a trial comparing ketamine or MDMA with and without psychotherapy, or with and without certain types of psychotherapy.
Thank you so much. And we have to move to the next